Thank you so much to the rest of you for staying till this last session. It's my pleasure to present some of my work here. I have the pleasure of actually working in a quite a large university medical center, which is located in the Netherlands, in the south of the Netherlands. Well, there's not a large difference between north and south. It's maybe 300 miles, that's it. So it's more of a, country around Amsterdam. Does who of you also works in a hospital or a medical center? Hands, please. Oh, okay, that's not too bad. It's about 20–30%. Okay. And who has private practice? Okay, yeah, that's usually the rest of it. Okay. You can see actually we have a team in place of both researchers, psychologists, ENT doctors, and actually in our tinnitus team is also a psychiatrist usually. And when needed, we cooperate with neurologists. So that feels quite luxury. I'm involved in both in clinical practice and in research, and I really like to combine these two. So I'm going to talk about both a bit. Because one of my missions will be to do research that is clinical based, but also if we have a research project that works, we want to translate it again to the clinic to make it work for patients. So it's really a constant going back and forth from patients' complaints, going into the clinic, going into research, and then research, thinking of new ideas and trying to make that work for patients. In my opinion, it always starts with patients' complaints. We want to help them, of course. I think all of you are committed to that too. So what are patients' complaints? Well, I'll usually give this demonstration. That's audible, yeah. It doesn't seem, it seems quite simple. Already, my apologies for if that might be too disturbing. It seems quite simple. Everyone knows it. It's just a sound in your head that is constantly there. And if I keep on talking, well, you can just listen to the sound and it might irritate you. And if I keep it on and I keep on talking, it might feel, you might feel a bit frustrated, right? Anyone feel frustrated? Even if I mention it, you feel even more frustrated, right? You could even get mad at me. I'm going to back up a bit. Stay there. So it's these feelings of frustration and madness and anxiety that are, of course, really the problem. And then what do patients ask from us? Well, of course, they ask to shut it down, of course. Well, I'll try. I think it's broken, sorry. No, it's not working. I'll have to leave it on, sorry. So just go on and lift it up while I'll do my talk, and then you'll be fine. No, I actually can switch it off. And even though I've done this demonstration many times, I still myself feel a sigh of relief. Unfortunately, some of you really have tinnitus. Huh? Some of you are patients and don't have this sigh of relief at this moment. But I think it's very natural as a patient to want this stop button, as I call it, this sigh of relief to stop it. This demonstration serves to show that it's not a simple problem. It's a complex problem. It's a complex system, and so there are only complex solutions. And that's why we have a complex clinical workflow in place. We see about 600 patients a year, and they always start with questionnaires. And based on these questionnaires, they get seen by an ENT specialist. And the ENT specialist discusses the questionnaires and does a full anamnesis, and if he wants, he does imaging. And based on these questionnaires, if the TK grades are low, that is, the complaints aren't that high, we only refer them for group education. Only one session, maybe 1 hour, maybe 1.5 hours, and that's it. Most patients are satisfied by that. If the complaints are higher, grades 3 and 4, so that's severe to pretty severe, they get an individual intake with the same information, but then more individually based. And we also do a HATS, that's a Hospital Anxiety and Depression Scale to screen for psychiatric disorders. In fact, 1/3 of our tinnitus patients has a psychiatric disorder. So it scores high on anxiety and depression scales and is seen by a psychiatrist for that matter. And after these first sessions, our patients are discussed in the team, and we discuss with them what will be the further intervention plan. Both counseling sessions, psychological sessions, or sometimes noise generators or otherwise. And of course, we do questionnaires afterwards to see if there's a difference. To give you an idea of our population, well, it's quite broad, from light complaints on the left to severe complaints on the right, just a histogram. And to the right of the orange bar is the 1/3 of patients with severe complaints. So we see these individually. And if we, I don't have a picture of that. This is pre-TQ scores, so that's pre-intervention. In post-intervention, we saw a reduction of about 10 points. That is, to remind you, it's not a long-term intervention. It's not 10 weeks of intervention. It's only maybe maximum 4 to 5 hours of counseling, maybe a noise generator. Just very quick, small intervention to make at least a clinical significant change. Okay. But you need, in my opinion, I really love this complex multidisciplinary team. I really like it that we have ENT specialists within our team, psychiatrists within our team, so we don't have to refer back and forth to each other. And patients, of course, like that too. All right. And then you have all these treatment options, which you can do extra on that. A lot of have been discussed already. You have sound enrichment, peripheral, I'll talk about that a little bit, which CI might be an option. CBT, of course, is the only effective, proven effective treatment so far, and antidepressants too. SSRIs were mentioned before. And yeah, of course, there were several which were shown in a research setting not to be effective. You can see them here. I'll make a small sidestep to neuromodulation in the sense of real DBS, deep brain stimulation. Just a small sidestep. We've actually have some good experiences with that in rats for the past 2 or 3 years, just to try it out. And how did we come up with DBS? Well, this is the setup. You have a stimulator here, and then it's quite invasive. You need a neurosurgeon to put this electrode in place. But the nice thing is it's already available for about more than 30 or 40 years. 30 years, actually. 1987 was the first, and it's been done, and it's been effectively in many diseases and many symptoms. So why not tinnitus? I mean, these are all problems in the thalamus, problem in the brain. So it's available and it's there, and you look for new applications of existing interventions. And it was quite effective in rats. With a review on that, and you can have a look. We're actually going to start a trial probably at the end of this year or beginning of 2018 to do that in maybe 4 or 5 humans. Okay. The other thing that's already readily available and safe, and we've been doing that for more than 20, 30, 40 years, is of course this CI, this cochlear implant. And we know from literature that it's quite effective in also treating tinnitus. So usually it's mainly the hearing, which is the indication. But if you look at patients which were implanted based on single-sided deafness, we did a review on that in 2012, and it showed that the majority of SSD patients, with single-sided deafness, actually experienced quite a large tinnitus reduction after they were given a CI. Even better, none of the studies showed an increase in complaints. So you can actually just do it and try it, for instance, and you can never go wrong within a lot of limits, of course. You have to make sure it's safe. But the results were actually, if we look back, were promising. Now, we broadened that a bit. We, of course, know from clinical experiences that cochlear implants also reduce tinnitus in bilateral deaf patients, in the classical CI patients. We now know that it reduces tinnitus in, the vast majority of SSD patients. There's only a small chance of tinnitus getting worse. And you have this iterative electrical stimulation. That's some sort of an alternative to cochlear implantation. You can just, it's been done by Chang and Zhang, to just see if you, instead of environmental noise, environmental sounds, you can switch off the microphone and just put an electrical pattern in there. And would that work too? Well, actually, it seems to work, at least for minutes. It has been tested until then. So we thought, yeah, well, let's just try this. It seems to be quite an inspiration. CI reduces tinnitus, it's safe, it's there. So it might actually be what I call the stop button candidate. I should mention, stop button candidate, yes. But I tell all my patients, even the CI is also a simple solution for a complex problem. So that actually reduces expectations. Also from this research point of view. Yeah, I will get philosophical. The hard thing is, in clinical research, or in clinical work, we tell patients it's a complex problem, you need this full multidisciplinary team. In research, we tend to choose one option to take out and to see if that works or not. Because you can't test 3 options at a time. You need one option which you can turn on or off. I mean, that's a classical research problem. So you can't do this whole team and say, this is effective, so let's do everything. So you have to do it one by one by one. But with reduced expectations. Okay. So then our main question was, why does this CI work? Is it the meaningful auditory stimulation? Should there be environmental sounds and speech? Or can you also turn off the microphones and just introduce some sort of electrical stimulus, which is meaningless, as a masker maybe, or as an electrical alternative for just the acoustical noise generators. Okay, and we call this question the cochlear implant, this with the environmental sounds, versus the tinnitus implant. So actually, the tinnitus implant, as we call it, is nothing more than a cochlear implant with the microphones switched off, but with electrical stimulation. Okay. We used Madel electrodes and processors in this research. And we actually looked, well, as I said, cochlear implant versus this tinnitus implant or pattern generator. There's this processor, the Opus 2, the older processor was there, has a 128-bit random access memory inside in which you can just program a pattern. We used all kinds of patterns like sinusoids and flat patterns and white noise and all different kinds. And this is an example of a, well, speech-like but noisy pattern, okay, with speech modulations. Okay, I'm doing on the time, okay. So this was a protocol we included. We implanted these 10 patients only, and then they got a standard CI. We tried a lot of different patterns. Then we did a placebo stimulation, and we randomized 5 of them. First got a normal CI for 3 months, and after that they switched off for 3 months and used the pattern, and the other 5 did it the other way around, and they got to choose in the end. Okay. Then results. Does it work? Yep, seems to work. This is a VAS and this is a TQ. No, let's first have to focus at the VAS scale. Much complaints at baseline, a bit lower when we post-op, but after CI rehabilitation, so that's about 3 months, the VAS was mainly reduced. Where we deactivated the CI and asked for a week later, the VAS was increased again. So that's what we expected. This picture is a bit complicated. On the horizontal axis, you see all the patients, so from 1 to 10. And on the vertical axis, it's tinnitus suppression in percentages. So in this orange area, there's not much suppression at all. And in the blue area or the green area, there's more than 30% suppression. And every blue dot here is a pattern which we tried. So you can see for some patients we tried, well, at least 40 to 50 patterns. There was 1 or 2 patients in which we only tried less than 10 patterns because he just said, okay, I'm not going to like this. I don't want this. And this patient number 2 actually busted out earlier. She had some psychological problems too. Yeah. The nice thing is, for most patients, we found that at least one pattern was effective in reducing the tinnitus. We couldn't, however, really find any pattern in the patterns. There wasn't like one pitch match, or maybe we tried the sinusoidal, was that bad or nope. There wasn't really a clue. We didn't have a clue on how we should, so there was nothing left than just try. The only thing we found is that louder patterns, louder sounds are better at reducing tinnitus than softer sounds. But that's probably the masking effect, which we didn't want. So, sorry. Okay, long-term results then. Okay, so that's after 6 months, the VAS was still reduced, and DQ score, well, was also reduced by 10 points. We also compared, don't show it here, we compared the TI versus the CI, and there was actually no treatment effect. So the main question, is it the environmental signs, or is it the pattern? They both work the same. They're both as effective as in reducing the tinnitus complaints. Okay. When we ask people to choose, of course, most of them, 9 out of 10, choose the CI as a preferred, because they also are better at hearing. And only one found it better to use the pattern generator. Okay. Yeah, that's the result. Significant stable reduction of tinnitus complaints. All right. So to conclude, what we saw that in both classical and in this study we tried SSD patients, that's both the CI and this pattern generator reduced tinnitus complaints. So we think that with tinnitus really can be the primary indication for CI. And as I discussed, you should always look, we are now in a discussion, which patients do you give the CI? I mean, you don't want any tinnitus patients to just implant. You need, of course, hearing loss, but what kind of hearing loss? And we think you would also require, well, you just first do all the other options like CBT or mindfulness or sleep, and only after that doesn't work, you would even consider implanting patients. So we're going to do a follow-up trial starting end of this year, in which we're trying to answer those questions. So what is the place of this cochlear implant within the full spectrum of healthcare that we can provide? And we hope to have the answers to that in about 3 or 4 years. So which inclusion criteria should you come up with to really be confident that if you implant CI for tinnitus, that it's also going to help. Yeah, we're really looking forward to DBS results too. Okay, so that's it. Thank you so much.